Thanks, everybody. I'm just going to share screen and then I won't be able to see anybody. So if people are asking questions or anything like that, I won't be able to
I'll
tell.
let you know. Don't worry.
Am I sharing screen?
You are.
Thank you. Can't see anybody. So, which always makes me feel a little bit funny. I was expecting about 10 people today. So clearly, you're all very, very interested in what George has got to say, and rightly so. But I will just take you through some work that we've been doing in LLR using our population health management system. So I'm Janine Dellar, for anybody who doesn't know me. I'm the head of strategic intelligence at LLR ICB, and I wanted to use this forum to share some work that we've been doing using our population health management system. It's quite a good example of figuring out a way to work with data to build good enough evidence to support the decisions that the system was trying to make at a time. It's not a clean piece of analysis. There are loads of caveats in the methodology, but it did provide us with the evidence that we needed to support the system to make a decision about continued investment in a core service. And it's something that I'm really interested in. It's what we can do in the space, that's doing the best we can with the data that we've got to move decisions forward. So we get stuck in this, we haven't got the data isn't quite right, but actually we generally don't need perfect evidence to make decisions. We need to be able to get our evidence good enough to support the decisions we want to make. And I'd be really, really grateful if you can keep some of that in mind for our questions. So what am I here to talk about? I'm here to talk about our complex care programme. Our complex care programme is a primary care programme that has traditionally used our population health management system to identify the patients that are at high risk of hospital admission, to prioritise these patients for a care plan. These are patients that have complex health and care needs and would benefit from a more structured medical and care review. The aim of the programme is to improve outcomes for patients with an expectation that the proactive care would lead to reduced GP appointments and a reduction in unplanned emergency admissions. Our current scheme has been in place since 2022. In 24-25, we added just over 13,000 patients to the programme, and we needed to submit a business case last year to support continuation of the service. And we needed to provide evidence that the service was delivering the right outcomes for both patients and the system. So I thought it was just worth spending a bit of time thinking about why we set up the scheme in the first place. So just looking at our population health management data, in LLR, we use the Johns Hopkins Adjusted Clinical Groups for our PHM algorithm. It's a link to primary care and secondary care data set that stratifies our patients based on need. We know that our strongest predictor of acute health and care needs is multimorbidity, and the number of longer-term conditions that a patient has increases their risk of hospitalisation. So if you look at the triangle shows you for LLR on the left-hand side, the proportion of the population with long-term conditions, and on the right-hand side, our acute hospital spend. So for LLR, 49% of our population have zero long-term conditions. This population accounts for 7% of our acute spend. 29% of our population have 1 to 2 long-term conditions, and they account for 16% of spend. 11% have 3 to 4 long-term conditions, accounting for 17% of spend, and 11% of our population have 5 or more long-term conditions, and they account for 61% of our acute spend. And this has kind of driven the work that we've done to understand patients, patient complexity, and the idea that we need to support patients with complex multimorbidity in the community in a transformative way to help us to reduce the need for acute care. So across LLR, we're increasingly using patient need groups, or PNGs, if I slip into acronym land during the course of the presentation. And we use our patient need groups to help us to understand health and care needs of our population. So it builds from our kind of multimorbidity, our long-term condition, but also further segments the population in different ways. We've got 11 patient need groups, and they range from non-user through to frailty. And as we move through the PNGs, the level of need in each segment increases. Segments 4, 5, 10, and 11 are all linked to multimorbidity with an increasing level of complexity in their health and care needs. PNGs 6 and 7 relate to pregnancy and the specific health needs that relate to a pregnancy pathway. And PNGs 8 and 9 are single conditions. PNG 8 is dominant psychiatric and behavioural conditions. PNG 9 is a dominant major chronic condition. So before multimorbidity really kind of becomes an issue for those patients. And these are all built within our PHM system. And one of the, as I said, one of the core components is multimorbidity, but we've got other factors that we bring in to kind of reflect complexity, things like polypharmacy, things like their acute hospitalisation. It's all kind of built in the background from a number of health and care markers. And this just takes the triangle and demonstrates it using those patient need groups. And again, we've got population on the left-hand side and spend on the right-hand side. And you can see PNGs 10 and 11, they're a tiny little blue dot at the top. These are our patients who are frail or multimorbid, and they account for 3% of our total population, but 38% of health and care spend. The average acute spend for this cohort is £3,800 per person per year. And using the data in this way starts to build our understanding of the cohorts, and we can start to use that to help us to transform our services in a way that's targeted at meeting the specific needs of different segments of our population. So evaluating our complex care service, this work started back in November. The clinical lead for the service asked us to develop a matched cohort analysis to evaluate the effectiveness of the service. We couldn't do this. We didn't have the right data flowing into the system. We didn't have the underpinning information governance in place to allow us to do it. We just didn't have the data infrastructure to support us to do it. In our PHM system, we knew that if a patient had a care plan, we didn't know when the care plan was put in place. We didn't know if the care plan had been put in place because of the complex care service. It's the usual thing. The service didn't have evaluation built into the service design, and we were trying to retrofit evidence to the service. We went round and round in circles for a few months. We got quotes for a full evaluation. We explored the IG barriers that we need to work through to undertake the evaluation. But we were mid-planning round and we needed something quick, and we didn't have any money to go out and commission the kind of evaluation work we were being asked for. So after going round and round in circles, one day in January, I just decided to ignore what we were being asked to do and thought about the question we were actually being asked to answer. Fundamentally, we wanted to show whether care plans made a difference to patients' health and care outcomes. And the main indicator we wanted to use for this was to see if the presence of a care plan reduced a patient's likelihood of emergency hospitalisation. So I figured it was worth just sitting down and crunching the numbers to see what they showed us. So using our anonymous and aggregated data from our population health management system, I pulled the patient need group, the care home indicator, patient count, counts of hospital admissions, so non-elective hospital admissions and total hospital admissions, ED attendances, total admitted patient care, and our indicative spend in acute providers. I crunched the data for all of our PNGs, but the ones of interest are PNGs 5, 9, 10, and 11. They're the cohorts that we really wanted to target our understanding towards. Just to reiterate, I always knew it wasn't a clean piece of evaluation. We don't know what kind of care plan. We don't know when it was put in place, and we don't know anything about the quality of the care plans. but I did want to use data to try and move some of our thinking forward and to kind of support the decisions we were trying to make. And I thought this might give us some reasonable results. So when I looked at the data, and we looked at the data around about relating back to December 2024, we had 100,000 people on the system with a care plan. As I said, we can't link the care plans to the data from the complex care service, but we know that we funded 13,000 through the complex care service in 24-25, and the service has been running for a while. So the current service has been in place since 2022, and we've had similar services running through the CCGs prior to 2022. So a chunk of the care plans that we've got in place will be related to the complex care spec, but we'll have other patients who've got things like an end-of-life care plan, a care homes care plan, single condition care plan. And we knew that we couldn't put that link together, but we could look at whether care plans offer protection against emergency hospitalisation. When we looked at it in detail, 78% of our frailty cohort have a care plan in place. 43% of patients in PNG10, the multimorbid high complexity, have a care plan. 21% of PNG9, the dominant major chronic condition, had a care plan. And 23% of PNG5, the multimorbid medium complexity, had a care plan. So we've got good coverage across the population in each of our cohorts, but more patients could potentially benefit from having a care plan in place. I know you can't see this, so I'm not going to dwell on the table that you can't read over the screen, but in terms of analysis, I generated crude rates. I significantly tested the crude rates within each patient need group. So the color coding just shows you whether the result for patients with a care plan or patients without a care plan is significantly higher or lower than the average for the patient need group. And just kind of eyeballing where you've got the green and the red, PNGs 4, 5, 10, and 11, you've got really clear statistical significance in the results for each of these, with patients with a care plan having significantly lower rates of hospital activity than patients without a care plan. So this just illustrates it for each of the PNGs of interest. I'm going to skip through these quite quickly and just pull out the highlight results. Starting with PNG 11, 78% of patients in PNG 11 have got a care plan. And we were able to demonstrate that for patients without a care plan, they had 31% higher attendance rates for ED attendances, 44% higher admission rates for non-elective admissions, and 50% higher overall admissions for total patient care. So really, really strong relationship there with patients with a care plan and without a care plan. For PNG 10, we still had a strong relationship, but it's not as strong. We've got a 9% higher rate for patients without a care plan for emergency care, both ED attendances for the patients with no care plan in place. For PNG 9, we got a completely different set of results. This is our major chronic conditions. We didn't get the same results. For total admitted patient care, we got a significantly lower admitted patient care rate for the patients with a care plan, but we don't see the same differential in the urgent care indicators. 22% of patients had a care plan in place, but it doesn't seem to have the same protective factor for emergency care as it does in the other patient need groups. And PNG5, we got another very strong relationship. So patients with no care plan in place for PNG5, which is multimorbidity with medium complexity, we had 32% higher ED attendance rates and 20% higher non-elective admission rates. This is my favourite methodologically dodgy slide in the whole pack. As soon as you do this, people want to know what it costs. Can you demonstrate savings. I know this is methodologically really iffy and the numbers are only ever going to be indicative, but it has really, really helped with the messaging to put some pounds against it. From the data that we had, we've generated an indicative financial value for each patient need group and demonstrated a potential cost benefit of a care plan of £2,176 for every patient with frailty with a care plan in place, £637 for every patient with multimorbidity, high complexity with a care plan in place, and £121 for every patient with multimorbidity with medium complexity with a care plan in place. I know these numbers are starting to kind of get quite creative, but I think fundamentally we can say to the system, care plans are good for patients and they are good for the system. If you have a care plan, you will have lower rates of acute hospitalisation, lower ED attendance rates, and it will save the system money potentially. So our conclusions, we've got 100,000 people in LLR with a care plan recorded on the ACG system. We can't attribute these care plans to the complex care spec, but we know that about 13,000 new care plans were put in place through last year's scheme, and quite a big chunk of our care plans will be attributable to the scheme. For patients with a care plan in place and a PNG of frailty, multimorbidity, high complexity, and multimorbidity, medium complexity, we've got significantly lower rates of hospital utilisation and healthcare spend for patients without a care plan. And whilst the analysis is unable to specifically assess the impact of the complex care specification, it does provide evidence of the effectiveness of care plans in primary care. And I think we can conclude that any scheme that increases the number and quality of care plans will deliver value for money for the system and improve patient outcomes and should be supported. So we were able to use the data to justify future investment in the complex care service and secure funding for an additional 16,000 care plans in 25-26. We did prioritise PNGs 9, 10 and 11. I've got to say, I'm still not entirely sure why we went with PNG 9 rather than PNG 5. It's not where the data led us to, but that was a managerial/clinical decision that was based on a range of other factors about the patients in PNG cohort 9 linked to improving the effectiveness of care in that cohort rather than targeting the emergency hospitalisation. But I am really, really pleased that we managed to get something done in time to support the business case, and really pleased that the work that we did helped to kind of support that decision going forward. Thank you for listening. I hope that was useful. Has anybody got any questions?
Thank you, Janine.
And sorry for speaking so fast.
You didn't speak so fast. You clearly haven't listened to me. when I'm in presentation mode. No, that was great. Thanks ever so much for sharing that. I think it's obviously you pointed out that you were not concerned, but there were caveats with how you approach it. But that aside, I still think the conclusions and what you've learned from it is pretty stark for the groups that you're most interested in. So I've got a couple of questions maybe, but I'm not going to say them right now. We've got one on Menti, which I will sort of mention before we hand over to George, so we'll give George plenty of time to share his slides as well. So the one question was, I don't know if you're logged on, you'll be able to see it, but the question was, did you investigate the possibility of reverse causality? I.e., could patients with, for example, well-controlled conditions be both more likely to avoid admission and more likely to have a care plan? That's quite a hard question.
That's a really hard question.
You can think about it.
Can you send it to me afterwards and we will have a think about it? We know that what we could do with the data was methodologically unsound. We have proved that people with a care plan are less likely to be admitted through ED, which is good and positive. I don't think we can look at much else with the data. We have got plans to do more evaluation work in the future, and we have got plans to look at the quality of the care plans. What I will say is patients that are well managed are more likely to be in PNG for multimorbidity, low complexity, being well, the PNG 10 high complexity are patients that aren't well managed because they're already tipping in and out of hospital for various reasons. So I think I think the answer to that is probably in some way built into the weightings that sit behind the patient need groups, if that makes sense. And you're more likely to be well managed if you're in PNG 9 than if you're in PNG 10.
Yeah, I understand that. There's a couple more questions that have come up. Thanks for that. But I've also got David with his hand up. David, do you have a question or a point? Are you talking? You might be on mute.
It's more a point than a
Okay.
question. I'd just like to say congratulations on taking a pragmatic approach, and this just shows the
Agreed.
value of taking pragmatic approaches and pragmatic analyses and being completely honest about the methodological differences or difficulties. So congratulations.
Thank you. I think one of the things that hampers us in a lot of the work that we do is the fact that we all do a lot of this kind of work, and this kind of work doesn't get shared very much in the public domain, but we can all learn a lot from this kind of work, and we can't just wait for high quality peer reviewed research to guide our understanding of the evidence base. And it's one of the things that I believe really strongly in is actually this kind of network is our kind of opportunity to share this kind of thing in a way that drives and improves the work that we all do locally in the work that we do. And I think it's really important from that perspective. But thank you, David.
Thank you. And I'd agree as well. So we have a couple more questions, but I think we'll
do you want
I'll share those with you after. Yeah,
I was going to say, do you want to move on to George, and I'll pick up questions after?
Let's do that. George, over to you.
Okay, thanks. Are you sure? I probably don't have half an hour of content, so I don't know.
So that's all right, because you haven't got half an hour. That's fine.
Oh yeah, sorry. Okay.
No, we'll work it out. We'll sort of we'll be flexible. If we don't have time, I can always share them after. Okay.
Cool. Can everyone see that full screen? Cool. Okay.
See that. Is it full screen? What have I done? I'm just wondering if I've got it set out.
George, right. I've got you and the slides. Is there a way to get rid of you?
I know what I've done.
I can get rid of George.
What's that? Yeah, I know what I've done. Sorry, that's really stupid.
That's all right. That's okay.
Right, is that better?
No, but if I stop highlighting you, it might. Is it on a PDF? Is this the PDF version of? Okay, I've taken you out, and now I think it's okay for everybody. I think that's all right, isn't it, Janine? Agreed. That looks good. Let's go for that. Full screen, yeah, perfect.
Okay, cool.
Perfect.
Right. Hi everyone. My name's George. I am a data scientist at the University Hospitals of Leicester. My position's quite a unique one in that I don't really work within a business intelligence function. I work for the Director of Health Equality and Inclusion, the Trust. So my role is basically focused on doing computational work related to health inequalities and trying to leverage some of the trusts and the acute trust providers' data. Today I'm going to rather selfishly talk about health inequalities in emergency department data, and I'm going to hone in on kind of more of a methodology session looking at inequality measurement. So my overriding message throughout this presentation is that I think we're very good at looking at differences, health differences, but we could actually strive to do more work on health inequality. And I'm going to show you some, what I think are hopefully quite simple ways to do that are borrowed from other disciplines I myself, full disclaimer, I'm an economist by background, so most of these tools come from that space. But methodologically, I think they're readily transferable. So just to set things up a little bit, as we all know, health inequalities often fall off the list of priorities when budgets are constrained. For a data-oriented perspective, I want to ask why this could be. Can we actually do better? Do we have to bear some of the responsibility for this, or is this completely out of our control? So for me, health inequalities analysis often looks a lot like splitting and then aggregating data to identify differences. This is a really powerful approach. It's very easy to communicate. Often we can do a lot of different work with a lot of different methods. We can test for equivalence. We can do regression analysis, etc., etc. For me, there's two problems with this. One, it's really easy to miss subgroups. We're only looking at between group inequality, and to be a little bit blunt, it's not really health inequalities analysis, but health differences analysis. So today I'm going to present some work which is kind of like, it's very much work in progress. So I'm looking forward to hearing your comments, criticisms, rebuttals. But it's born out of some initial sort of mapping work we did of our ED attendance data that just looked at the kind of the decomposition of ED demand. So I'm trying to take this a step further and look more at, I guess, if our initial work was health differences analysis, then I would argue this is trying to look a bit more at health inequalities in my definition of the word, I recognize, of the phrase. So I'm going to try to make some progress on the latter concern. So I decided that we're not really doing inequality measurement, and I'm going to leave this sort of identification of subgroups for another day. Although I do think what I have to say has some bearing on that as well. So I'm going to focus on do a methodology focused intro to quantifying the magnitude of inequality in a private ED provider data set. I'm going to use three key tools. These may be familiar to some of you, they may not be familiar to others. Lorenz curves and Gini coefficients, these are really common. You know, if you talk about income inequality, these are kind of the standard tools in income inequality. And then I'm going to do a decomposition of inequalities between groups and within groups. And I'm going to use a Thale indice or Thiel indice and use a decomposition associated with that. So these tools, in my mind, are quite powerful because they can capture differences in the distribution of health outcomes, and that can also be informative about within group inequalities. And when we do find that there are really big, large within group inequalities, then I think that can motivate us to push harder on redefining some of our subgroups. So thinking harder about whether it's not just ethnicity that matters, that maybe it's, you know, an intersection of ethnicity and deprivation, and to go further and further, digging into subgroups there. So this, just to illustrate my point, or try to at least, this is kind of the approach that I took with the ED data. So this is a live example. We had ED data come in from the business intelligence team, and I split the data by month and year, and by, this is just adults actually, and so by adulthood, and then also by ethnicity, and I plotted wait times, the median wait times by these different groups. Somewhat surprisingly, what we found was that white individuals were waiting quite a lot longer. There's a result that's, I think, a little bit surprising, but, you know, I'll just tell you now. So, you know, so that actually we found this result was completely driven by the underlying age of these individuals rather than their ethnicity. Similar story for deprivation. In recent years, we've discovered that the least deprived are waiting longer, and that again is driven by the fact that they are on average older than the rest. So these are health differences, and they would have left us with so what takeaways would we probably have drawn from this? Well, superficially, we might have just said white and less deprived individuals wait longer. We might have dug a bit deeper and said, oh, and realized that maybe actually this is just driven by age. And that might have led to some sort of intervention. The problem is that actually this is quite inefficient though for intervention targeting with limited resources. And that actually within ethnicity, what we discovered was that the inequality was far greater than between ethnicity in this particular case. Not always going to be the case, but empirically it was here. So this sort of prompts our my mission to focus more on decomposing total inequality into between group inequality and within group inequality. So to first and foremost ask, how unequal actually is this population that I'm looking at data for? And then to ask so that's a sort of a mapping exercise. And then second of all, to ask a sort of a so what question, which is, okay, so if I were to solve this between group ethnicity, how much of the overall problem of inequality have I actually solved, or health inequality have I actually solved? So there's sort of just in a nutshell what I'm trying to do with these tools. So my first tool, as I mentioned, is just a Lorenz curve. So it's a graphical representation of the distribution of, it says income or wealth, but it could be, in this case, we're going to use wait times in a population sample of data, and that can help to visualize the level of inequality. We can plot the Lorenz curve, so between or within group inequality analysis. But actually, I'm just going to use this first and foremost to look at between group inequality of wait times. And the reason I'm going to do this is just because I think before we start to look at within group inequality, we need to get a handle on what the between group is. So my methodology for doing this is that I'm going to group data at the ethnicity or IMD decile level, and then I'm going to calculate a group totals for wait times. So if I had 200 white people in my population, and they each waited 10 minutes, then the group total will be 2,000 minutes. I then normalize that group total with respect to the population total. So say the total wait time across all groups was 10,000 minutes, then basically 20% of the share for white individuals would be 20%. I'll then rank those groups according to their mean wait time. Sorry, I realize this is quite involved. I'll get to the graphs in a minute. And then I'll basically just calculate the cumulative group shares and plot them. So I'll come back to that, but this is basically my first Lorenz curve by ethnicity. So as you can see that by the fact that, and I can compare this to, so I plot this level of inequality here. So this here corresponds to a very small ethnic group, a little bit more, and this basically all of this, for all of the area from 0.4 on to 1 is basically the share of the white population. So what does this tell us? Well, basically, if the 45-degree line down the middle is perfect equality, anything below the line of the curve, any curve below the line is showing some sort of inequality. So for the pediatric sample, we can see there's basically no inequality by ethnicity in our sample. But for adults, there's actually a growing amount. And so already we've got some traction on the problem of how much inequality is there in our sample. We can summarize this in one measure, because I realize, that it's I haven't really told you a lot there, in a Gini coefficient, so which is basically just the area between this 45-degree line and that Lorenz curve there. So the bigger the area, the more unequal the sample or the population of patients. I can do the same for deprivation. Here we're seeing that actually in this particular sample of ED attendees, that there's not loads of inequality by deprivation. Deprivation doesn't explain a huge amount of the inequality, but there's definitely more. And what we see is that actually there's a little bit by pediatrics as well as adults here. So deprivation does seem to matter for pediatrics a bit more. So my takeaways from that were that it really is that this gave us a good handle on how much between group inequality is present. Frankly, my answer to just eyeballing those data sets is not loads. We're not helped in this particular case by the fact that we don't really have benchmarks. So because these tools aren't widely used in healthcare yet, we're not able to compare a Gini coefficient in this population with a Gini coefficient from another population that we know to be more or less unequal. But I still think it's useful, and it's getting to this kind of mapping question, which I think is our first port of call on this. However, I will kind of want to move forward to, so if that was between group inequality, I now want to look at a comparison of between group inequality and within group inequality. So, and try and map this for the entire data set. And so to do this, I basically need a measure of total inequality, which I can calculate using by calculating a Thiel index. And the great thing about a Thiel index is that mathematically it just reduces to between group inequality plus within group inequality. So it's an additive relationship, which we can just compare the difference. Some of you might be familiar with ANOVA. ANOVA does a kind of similar thing, but ANOVA is a test of group differences and actually relies on some really uncomfortable assumptions about the distribution of our health outcomes. It assumes normality, where basically in wait times, if you were to plot a distribution of any wait time within an ED, it would not look very normal at all. So this is kind of a more flexible measure. It doesn't rely on assumptions about distributions, and it's also quite simple because it's additive. So a bit on methodology. I'm basically going to, between groups, I can group my data by some characteristic, calculate group size, the group mean, the relative group mean, so that group mean relative to the overall population mean, and then produce a weighted contribution to between group inequality, and then within group inequality, I can go through the motions. Happy to chat any more about these calculations, perhaps offline, probably not used there. But this is sort of what we arrive at, right? And it's showing that naturally, as we make more and more, so as we define our groups, we get more and more traction on this between inequality question. So if we just split the data by whether someone's an adult or not, we're not actually able to explain very much of that variation in waiting times or that inequality in waiting times. When we add in age, life stage, we start to see a bit more. Ethnicity produces a bit more. When we add in deprivation, geography, frailty, priority, we start to explain just under sort of 40% of inequality by comparing groups, and the rest is still within group inequality, i.e. within a different ethnicity, age group, deprivation group, area of geography. There's still lots of inequality in waiting times, which we're unable to explain. I also have the same for bed weights and time to discharge. Roughly speaking, they look similar, although I would say that something quite interesting here is happening, which is that age and ethnicity age in particular, sorry, for time to discharge explains, a lot more of that inequality between groups. So overall, what have I presented today? I would argue I presented some less than groundbreaking results from a health perspective, but I have presented some what I think are interesting methodologies for studying inequality in patient populations, and in this particular case, in ED populations. These are very generalizable. You can use them to measure within group inequalities or between group inequalities. And then we can actually decompose total inequality into differences between known characteristics and differences within known characteristics. In a nutshell, we get a really good handle of what we do know in terms of health inequalities, and it informs us really about what we don't. And that, for me, is a really good starting point for if we're going to move into this sort of inequality measurement space, a good place to start. How can I extend this? Well, actually, if your measure of within group inequality is really high, then that's a good evaluation criteria for whether subgroups you're using as comparison are any use. So if you use ethnicity and it's not explaining very much of the inequality, then you probably need to think about more of an intersectional approach. It's also possible to do this within groups, as I mentioned. We can combine this with population data to calculate inequalities in representation. And also, if we want to really hone in on something, we can remove irrelevant sources of inequality. So, for example, you'll notice that arrival hour had a really big effect on inequality there. Well, actually, if I wanted to focus on sort of non-operational inequality or get rid of that, then I could just look at the residual after arrival hour, and look at between and within group inequality within that. Future directions. Since these are new tools, we really need to start using them in the context of healthcare to create benchmarks, or at least I think so. We need to have a sense of what level of inequality is natural or normal in, or is an average in healthcare. For those who need to focus more on demand management, and more on service priority than healthcare inequalities here, I would just mention that these approaches are basically equivalent with a difference in interpretation. What I mean by that is, you can view all of this through the lens of health inequality, but you can also view it through the lens of different usages by different groups, and that is so you can sell that very differently if you want to do. That is me done. I hope that was somewhat comprehensible and interesting, very methodology focused. So yeah, excited to hear questions if you've got any.
That was really interesting. Thank you, George. For I can see me. I can't do that. No, take me away. I'll stop talking. Okay. No, that's. Sorry, Janine.
Can I jump in? I'm really excited that we are looking at health inequalities in this way in LLR, and I'm even more excited by the fact that actually the drive for this is sitting within our acute trust, and it's a drive to understand inequalities with what happens to patients once they hit the acute trust. And I'm not really aware of this being done in many other places, and I think it's really telling that this is actually driving board level conversations within our acute trust. It's feeding through to our UEC partnership, and people are really excited about actually thinking about inequalities differently and using that to think about how we transform and develop our services in the future. So I'm hoping this was the right audience to bring that kind of methodological view of it. It's good to have some proper science behind it, and I'm really excited. I think watching how this evolves over the next kind of year is going to be great. So thank you, George. And it'd be really good to hear about anything similar that's going on in other areas. We've got quite a wide range of people on the call, so just understanding what's going on in other places would be really helpful.
No, absolutely, and it certainly is the right audience to come to, and there's probably other audiences as well who'd be very interested in this. But I think it's just having like a fresh approach to being able to measure health inequalities. Everybody. It's a well-used term, and people, as you were saying at the beginning, it's sometimes it kind of like it never falls off the radar, not anymore. But in terms of a focus and where people should be paying more attention when you have these financial constraints, and it seems to be a shift away from sorting that out and understanding that better to those very significant sort of financial pressures that people are experiencing, and so it gets sidelined. And so anything that can draw more attention to it and sort of excite people by understanding it and measuring it a bit better, if you can measure it a bit better in a way that is robust, it feels and understandable as well. I think the charts are very understandable. Then you can do something with that, can't you? You can explain it to other people, and I'm sure your boss was delighted that you're able to do that for him, and so that he's now equipped to go to his board, and he can use that information to sort of to make his case and to help him with the drive home the messages that he wants to share with colleagues, and to I suppose raise the level of importance in a way that people can see there is something that you can do about it as well. So anything that you can do, and methodologically, I think it's really interesting, your approach. I've not seen that on here before. We've had our health economics colleagues share their approaches, and there is some there are parallels, of course. That's where you say that's where you nicked it from. I heard you say that, George. So well done you. Yeah, no, I really enjoyed that. I'm just before I sort of whittle on. I clearly like the sound of my own voice, don't I? Today, I know I must have had a lot of sleep last night. So shut up, Caswell. What we got here on the questions? So. Somebody has asked, so I'm just moving on to the ones which were added since you did yours, George, but they might be relevant to both. So the first one was, do we have any data on private healthcare divided by deprivation decile? The least deprived might prefer private care or afford private care, and waiting longer for NHS care. So is that age, probably as an analyst in health or health and care, the age-old sort of problem challenge is, do we have any information about private healthcare, and are we able to reflect that in the analysis or the interpretation of what our analysis? George?
Not that I'm aware of, but I'll make excuses for myself and say I'm quite new to the NHS and the role in general. So it's definitely something. I think this substitution question around where people are going to their services is definitely something we want to do more on within the kind of health inequalities work that we're doing. Sort of that substitution and move from, we're actually trying to tie in some work with elective care as well. So looking at how, where do people go when this is a separate project, so kind of an irrelevant answer. But where do people go when they've got long waiting times? Do they go to ED? So to build in that private care analysis would be a really interesting aspect of that as well. But not that I'm aware of. Maybe someone can help.
Yeah, I mean, I think there's been. I'm going to come to you in a sec, Janine, but I think there's been quite a reasonable amount of research to estimate, at the very least, what proportion of care is bought privately. But it doesn't detract, actually, because you are just describing what you see, and what you see is what is NHS funded and publicly funded. So it's still 100% relevant, but it's just having that. That understanding of the other factors that have sort of play into sort of capacity and demand and so on. Janine?
I was just going to say that we get information on independent sector providers that are funded using NHS money. So in the same way that we do for all of our commissioned activity, we do get activity data on IS providers that we fund, but we would never get any information on privately funded healthcare, because there's absolutely no governance IG arrangements in place that would allow that to flow.
Yeah, absolutely. And I sort of we've been looking at sort of urgent and emergency services, and obviously one of the biggest factors when we're sort of playing in the community services and how it all relates to one another is all that stuff we don't know about the community services in terms of how much is privately funded, and that's when you're trying to understand those relationships, it does play into that a lot more, and we do sort of have to recognise that we only know part of the picture. Jonathan, you have your hand up.
Hi, my first NHS job was in an acute hospital trust as an analyst, and the first thing I did on any query was to exclude private patients from my analysis. So the answer is yes, we do have private patient information. The acute, it sits in the acute, so every NHS trust has private patients. They have all the data on it. And they don't necessarily share it with the NHS, because why would they? I think what's really interesting is what these analyses would look like if you put those patients back in the analysis that are excluded because they're paying privately. So there's a difference between inequality in people accessing healthcare and inequality in people accessing publicly funded healthcare, and they are two different things. And just, I mean, anecdotally, where kind of like everyone I know who's needed a hip replacement now has just gone privately. They're not using the NHS anymore. Obviously, they're in that fortunate position where they can afford that. But yeah, I think there's probably very large growing demand for private healthcare for some of these elective procedures, and yeah, they're expensive, so you can guess the impacts on who can afford them. But yeah, the data's there. It's down to the old thing of we don't share it. And just to say, George, I love the great to see the Gini coefficient coming into use. I used to use that and I haven't heard it in a long time, but it comes from economics, doesn't it? So no surprise you've come across it. But I always thought it's an excellent way to illustrate inequality in anything.
Thank
Thanks
you,
very much,
Jonathan.
Jonathan. And
Thank
yeah,
you.
very good to know.
That's really interesting. So we're learning more each day, aren't we? And you've got a new fan there, George, and you've inspired him to use some of these techniques which he may have used before. So we have just hit time. So any other questions I'll share with you after, if that's okay. I'll just share and before I do, and everybody disappears, just thank you so much, Janine and George, for sharing that with us. I really enjoyed the session. I do hope there's going to be a follow-up, George. I just feel that there's a lot more to be said, and I like the extensions and follow-ups that you'd mentioned. And so if you're okay in front of all these people, can I confirm that you're happy to come back? Future Huddle. Great.
Yeah,
so
yeah.
got that recorded. That's all good. I'm just going to share. I seem to have lost my Menti. Where has it gone? Yes, here we go. So I'll just move on from those. Just very quickly, I'll just say what's coming up in the next few Huddle. So, in fact, just mentioning about the left shift or the right drift, or more working communities and activity avoidance, everything that we are trying to achieve. And of course, it's one of the government's big priorities. Yes, I know we've been trying to do it for about 50 years, but it's going to happen now because we're getting involved and again to do something about that. So I really hope you can come to the next session, which is a colleague, Jenny Wood, and others here in the strategy unit. We're doing a lot of work around that, and actually we're adding some numbers to it as well. So let's see if you can come along to that, and I'd be really interested to see what you think about that. And then we've got our much promised strategy unit new hospital programme demand and capacity model that will be coming, but won't be coming before the contributions from my friend at Exeter Uni, that's Dan Isaac, and he's going to be doing a talk on humans, AI, and the importance of data literacy. I cannot wait for that. It's going to be really, really interesting. There are some other ones that I'm going to pop those on the website so you don't have to listen to me talk about them. We have a free training opportunity coming up, and that's Mohammed's Understanding and Reporting Hospital Mortality Statistics. First of all, we've got an online session, that's the 24th of June, and we also got an in-person session on 22nd of July, and that's in Stevenson Street in Birmingham. So do register for that. You can't yet because it's not available, but it will be soon. And then hop along. You might be interested in this, George. We got a reproducible analytical pipelines drop-in session with Chris Bealey on the 4th of June, and anyone can come to those. Here's the link online. Never know whether you can actually access this link. If you're interested, email me after, and I'll share that with you. So I went to the last one 2 weeks ago, I guess, and that was really enjoyed it at any level. But if you've got any specifics or challenging questions, yes, go. If you've got a challenging question, go along to that session. He really likes challenging questions. So thank you very much. So finally, back to stop sharing. Thanks again, you guys, for coming. And thank you everybody for coming today. Half term, and we had like 80 people in the room. So wow, we're all very interested in this topic. Enjoy the rest of your day, and I will see you all in 2 weeks. Okay, bye-bye.